Okay, so I think we'll get started. Welcome everyone to our second Arthur Summer Rotenberg Suicide and Depression Studies Program public speaker series on suicide research. I'm Sakina Rizvi. I'm the chair of this program here at the University of Toronto St. Michael's Hospital. So for those of you who are just joining us for the first time, like the goal of our ASR team in this lecture series is really to share knowledge and just get the really impressive research that's being done out into the world. So in that vein, if there's something that you want to know more about or you're curious about, please use our feedback form at the end of the talk and just give us some ideas and we'll try to find speakers for those things. We will be here monthly from September to June every year on Mondays, 12 to 1. So you can sign up for updates on who's coming next, and Jackie will post that link in the chat. And also there's a Q&A function at the bottom. If you are able to use that for your questions, that would be great. We'll also be monitoring the chat as well. And just as a reminder, while these talks, they're really meant to inspire people with all the work that's being done, we are still talking about a very difficult topic. So please be mindful of that and support yourself as you need. This session will be recorded and available on YouTube. So if you need to step away, grab a cup of tea, do a little dance, like do whatever you got to do to support yourself. That's the most important thing. So I'm absolutely thrilled to introduce Dr. Yvonne Bergmans, who I've known for many years. She's an incredible suicide interventionist. I'm not saying that because she was the one who trained me on suicide intervention. She really is just that good. She's also an adjunct lecturer of psychiatry at the University of Toronto. For over 20 years, Yvonne's clinical and research work has focused on creating relevant and utilizable interventions for people's experiencing suicide-related thoughts and behaviors. And with her clients, she developed the Skills for Safer Living SfSL group intervention, and she started that about over 20 years ago now. She runs training of SfSL to health agencies, hospitals in Canada and across Europe. In this talk, she's going to tell us about core elements of SfSL, some of the underlying principles and concepts, its growth and how it can transfer over time, and what some of those necessary skills are for facilitators working with this population. So welcome, Yvonne. Really excited to hear your talk.
Thank you so much. And welcome to all of those of whom I cannot see. And as Sakina was identifying, that we can get gut punched at any given time because we've all had experiences of one way or another, and it may or may not be suicide. And still we may feel ourselves getting a little bit activated. So as Sakina mentioned, taking care of yourself is the most important thing throughout this talk. Make sure that you're in a comfortable spot, you have what you need, your pet, your soft toy, your fidgets, your beverages. If you start to have a few little weepies, the SPURT program is something that I highly advocate. Just make sure you have some Kleenex for yourself. Turn off your camera or your sound if you need to. Contact a support person if you need. And take a wee nap if this session exhausts you, because it can do that. We can feel agitated or exhausted after a talk and wonder, what the heck was that all about? Know that your body is telling you, whoa, take some time, take a nap. So I'm going to run through a really quick history of the SfSL program. So we had our first group in February of 1999, and at that time, it was expressly for people with recurrent suicide attempts. I was hired to keep them out of the emerge as much as possible. And I guess within 3 sessions, folks were very, very clear about the fact that the manualized intervention I was using at the time wasn't resonating. So based on my previous 19 years in working with kids in special education, those who had emotional and behavioral challenges, I used that information plus literature searches, plus a program that I had worked in with youth called Protective Behaviors, and the whole baseline of trauma and being trauma informed was where we began. And my hypothesis at the time was the behavior is the communication of people's distress. They didn't know how to identify or name their feelings. So we were seeing it, and it was a matter of coming to understand it in a way where they could contextualize it and live with it if the thoughts persisted, because we know that thoughts don't just disappear for everybody. We know that it can be lifelong for some people, intermittent. There is no predictable pattern across the board. So in 2010, Canada Post gave a grant to offer the PISA program, which was basically the psychosocial, psychoeducational intervention for people with recurrent suicide attempts. And I was then informed that psychiatry really liked acronyms. We changed it to Skills for Safer Living, a psychosocial, psychoeducational intervention for recurrent suicide attempts. And that was the population we were working with at the time. It was a joint project between Self-Help Alliance and the CMHA in Wellington, Waterloo. And then in the last 15 years, it's really hard saying that. Anyways, we've renamed it again to Skills for Safer Living, a psychosocial, psychoeducational intervention for people with experiencing suicide-related thoughts or behaviors. It's a mouthful. We call it SfSL. And we have offered this group now for people with single or recurrent suicide attempts, people with ideation only. We have a concurrent youth and caregiver support program, and that's either offered in 4 weeks, 10 weeks, or 20-week programs. We have a 3-session safety planning intervention. In terms of the safety planning intervention, it's being trialed and researched in Galway, Ireland. And right now we're finding that their coping, their sense of occupational competence, their self-efficacy, and their reasons for living have increased. And the scores of the measures around burdensomeness and thwarted belongingness, those features decreased significantly, and all of the outcome measures were definitely significant. And we also, during COVID, under Sakina's leadership, and with her right arm, Alex Lalovich, we created a single session for people with ideation only, and that was across the country. And we found that at 3 months, they had reduced suicidal ideation, their depression and anxiety symptoms improved, their life functioning and their social disconnection. Again, the thwarted belongingness and perceived burdensomeness improved. So they also identified that they had skills to stay safer, even if they were experiencing thoughts of suicide. We offer the groups in virtual and in person. We did that pivot during COVID, and it works for, either one works for either. For some, it's just more convenient, given location. We run groups or have run groups in Calgary, Vancouver, Guelph, Fergus, Kitchener, Barrie, Cambridge, Toronto, and 5 locations in Ireland. One of the things that we want to do right from the outset is understanding suicidality from the perspective of the person. We want to understand their narrative. Underneath it, we are looking at what is the behavior trying to tell us. It's deep, it's painful, it hurts. So what we want to know is, what is it that you're hoping to end? What would suicide do for you? Or what would you hope will die? Very rarely do we get my life. Generally, it's the pain, it's the voices, it's a future with the same crap happening, feeling trapped, all of these kinds of experiences and feelings and life circumstances that people are undergoing. We also know that ideation is like an iceberg, right? You've got a lot of people who will have ideation, of which a smaller group will make attempts, and an even smaller group than that will have a death by suicide. So we have a real opportunity when people is expressing, or when a person is expressing thoughts of wanting to end their life. So this is from a study I did with young people, 25 and under, when they had first joined the group. And I was asking them, how did you understand your ideation or your thoughts? And here this young woman said, in my day-to-day life, the only little bit of comfort or joy that I was able to get was through interpreting life through death. And I got really good at that. I could see a string on the floor and I'd be, ooh, that reminds me of a noose, you know? And like everything was seen from the context of suicide and death. And that would kind of make me smile and be like, okay, this is still possible. This is my way out. This is something that I can still control. And being in want of control has been identified in other research as being all-embracing for folks with ideation. It can be seen in relation to the different aspects of how you interpret or understand yourself, your overall life situation, the immediate situation that leads them to the place of wanting to end their life and think that there is absolutely no choice and no control, or their outlook on the future. Another person said, you know, when I was talking about ending my life, I was saying, I don't know what to do. Somebody help me. Or suicide would be to never feel it again, because sometimes it becomes so intense. You get this feeling and you just want to burst out of your own body. The emotion gets so high. So for some people, it's a way of asking for help. For others, it might be to tell you how bad this really is and how bad and intense those feelings are. It might be to tell you how helpless or hopeless they're feeling in that moment. And it might be a way of externalizing what they're experiencing internally, whether it be physiologically or emotionally. And then there are those folks who sometimes see it as their identity. It is their fate in life. I saw myself as being completely useless, completely pointless, causing me more harm than good, and there was no reason for me, any of me. And then for the trans man, in the research that Gaveris identified, is there's a feeling of not fitting in, of being stuck, and of there being no possible way forward as an authentic and self-actualized person. So this fits in with Joiner's theory of burdensomeness. They perceive no value to themselves, for others, to themselves. They have very few, if any, connections, and it's basically their fate in life. So we want to ask about the narrative. And when we're listening to the story that our clients are telling us about their thoughts of ending their lives, we want to pay attention to, how do they perceive themselves? How do they perceive their relationship to other people? What is the degree of emotional intensity in relationship to that perception of themselves and their relationships to and with others? Again, have they got cognitive control? As one of my clients very clearly said, hey, Yvonne, when the emotions go up there, the brain gets left behind. In other words, as Sakina has very wisely told me, you know, when the emotions get really intense, your brain is offline. It's not your friend. And the experience of that intolerability and the perception of the inescapability can result in feeling trapped. And then suicide is just considered a great way to escape. It's the only way I'm going to get out of this situation. Again, there's very little, if any, perception of choice or control to the experience that they are having in the moment. So we understand suicidality, or the thoughts of suicide, as the early warning signs to some really big feelings. And those feelings, that experience, the internal, it's my guts, my head, it's my heart. Well, what's the story you're telling yourself about that experience? Are you saying, this is never going to end? I have to end it right now. Well, let's remember, your brain is not your friend in that moment of intensity. And it's going to be different for every person you ever meet, right? It depends on who you ask. For some people, there might be a situation which is really, really impactful, and somebody else might go, yeah, whatever, right? And we have to honor that this is the person's experience, regardless of what my formulation is in that initial conversation. We are focused totally on the person's narrative. So when we're looking at the core principles, suicide doesn't care what your diagnosis is, nor does it care where you come from, how much money you make, where you live. It's trans-theoretical, it's trans-diagnostic. We are focused expressly on you keeping yourself as safe as possible, regardless of the diagnosis that you have been given. When we're looking at inviting participants, it's an invitation to give themselves permission to engage with the possibility of choosing not to die. We're giving it back to them. I can't make you anything. And as one of our former group members identified, I alone need to do the work, and I cannot do that work alone. We deal with possibilities, not absolutes. And we use the word possibility rather than hope because clients have told us over and over again they can see hope as incongruent with their current experience, or they see it as dismissive. You know, somebody, well, I hope you don't kill yourself, or I hope I don't see you again in this emergency department. So we invite them to consider possibilities, that things will be different because, face it, 45 minutes ago, you didn't know what I looked like. Well, some of you, I don't know who's here and who doesn't know me, right? So there's something different. Even a small difference can be a big difference for an individual. Every behavior is a choice. Everyone here is human. And we want to get right back to connecting with the fact that you are a human being. Everyone in the room is both a learner and a teacher. I don't know everything. I have never known everything. I will never know anything. And the older I get, the less I know. So I'm curious. Tell me about that. Does this experience resonate for you? What's it like for you? You'd say that you have a very different experience. Can you tell us about that? And it creates wonderful conversations, either in the individual therapy session or in the group session. One of the questions that we'll ask is about the suicide continuum. So some people are living to die. That's what they tell me. This is research that came out of both the young people study and then later on when I worked with people over the age of 25, asking them what their experience was. So if a person is in a position of living to die, the question is, can you engage with the possibility of choosing not to die right now? By virtue of you talking to me and not having attempted suicide, it means that you're engaging with that possibility. Are you in fact choosing not to die in the moment? And how can we help you figure out how you can keep yourself safer, with emphasis on the and we'll get to that in a minute or two. There are people who are choosing to live in the moment. Yvonne, I'm not giving you any guarantees. I'm doing the best I can, living where I am right here and now. Very few people, and yet there are some who are just dying to live. They are out traveling and volunteering and having families. And then they call and say, I don't want to die. I'm choosing not to die, but I got those thoughts. Can you help me through this? Because it fluctuates for some people. The whole thought process that just sometimes envelops them. It could be a life change, it could be the death of someone, it could be anything for somebody. Those are the interventions when someone has reached choosing to live in the moment or dying to live, that when they call or reach out to say, I'm choosing not to die, and that's why I'm calling you, or I'm showing up in your office, those interventions are a whole lot quicker as a therapist and a whole lot easier because you know they have a skill set and a baseline to work from. The very first thing we're going to talk about are core coping skills. So when we talk about distraction, we're talking about drawing attention away from the thoughts and the experiences. And that can be any number of strategies, recognizing that one person's soothing strategy is going to be somebody else's coping distraction, or it's going to be somebody else's grounding. It's not a panacea. You want a whole list of things. And if one isn't working after 5 minutes, you try the next one and you keep on doing it. Because we know that the intensity of emotions does start to dissipate just ever so slowly. And we want to de-escalate that just a bit, to pay attention to that. Self-soothing, the 5 senses. And that's to help you feel a little bit calmer. It's not walking away. It's just to feel a little calmer. And then the grounding is to detach from that emotion and focusing on the external world rather than perseverating, or, you know, what some people would call navel gazing, right? Because that can throw you into the emotional salad spinner if you stay in there too long and you're already distressed. And we have a handout of probably 300 and some odd plus of grounding, distraction, and soothing strategy. When we talk with clients about feeling safe, and that's just a word we throw out, does the person even know what safe means? What does it mean for them? Some people have never, ever, ever felt safe. How do you know when you feel unsafe? And the safety continuum is something that we've worked with, and I initially learned in the protective behaviors program quarter of a century ago. How do you know when you're feeling safe? When is it fun to feel scared? Roller coasters. Some people like them, not me. There's not a hope on God's creation. Scary movies. I don't scare well. How about risking on purpose? Well, risking on purpose, it might mean going to the emerge. I don't know what it's going to be like, but I'll try it anyway. I feel really unsafe. I feel really scared. I feel really hopeless, and I'm still going to try. Coming to a group, I'm still going to try. And then how do you know when you feel unsafe? Having choice, having control, and knowing how long something will last helps us navigate feeling unsafe. It allows us to engage in either feeling fun to feel scared or risking, taking that risk to do something, even if I am experiencing these feelings. Well, I learned really, really early on was there was a real paucity of emotional language. Can you tell me what you're feeling? Well, it's like, well, you know, I don't know, overwhelmed, angry. And what Angus and Greenberg in the emotion-focused narrative therapy talk about is that undifferentiated states of high emotional arousal, or those unstoried emotions, are almost always experienced as disorganizing, distressing, and frightening. And that naming an emotion integrates that action, the emotion, and the meaning, And it also helps provide access to the story in which that feeling experience is embedded. So we work a lot on naming feelings. When we did some initial testing, alexithymia, which is the inability to identify or describe emotions, we found that over 80% of our folks were moderately to highly alexithymic. So in other words, you need to name it to tame it, as one of our group people say. I don't know that I'd be hugging tigers, but you could tame your feelings. If I feel sad and I can name that I feel sad, I've got a context. Yeah, this is what just happened. My kitty is really, really sick. Well, of course. And it's going to be unique to you, and nobody can judge. Nobody can tell you it's a good feeling, a bad feeling, a right feeling, or a wrong feeling. It's part of being human. It's got nothing to do with good or bad. It's about you're a sensitive feeling person, and that's okay. We talk about the early warning signs in part of our learning our emotional literacy. And it's tell me what is happening in your body. And we do it pictorially. We make it activity-based, we make it fun, and we all get giggles. And as a facilitator, I'm usually looking at my co-facilitators, we're throwing out stuff, and we're riffing off of one another, and we're getting good giggles. One of the things that I've often said to facilitators, if you haven't got the giggles happening at some point, something's not right. What we also do when we talk about the early warning signs is start differentiating and naming what is a feeling, what is a physical sensation, what is a thought. We often will, or we don't often, we always use a feelings wheel or emojis. For those of you who have like 150 Canadian dollars, ordering kimochis, which are little puff pillows with faces on them and a feelings word behind on the back of them. I've had 75-year-olds have as much fun as the 18-year-olds with them. And we can create all kinds of games in naming feelings, presenting stories. Guess the feeling. This is what happened. Blah, 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 blah. We talk about, and if there are any of our former group members, they'll see triangle. We do this every week after it's been introduced. The formulation is that when someone is expressing or experiencing high intense feelings, they have what Schneidman called psychache. It's that pain, and they move immediately into behavior or an action based on the experience or the feeling that they are experiencing. In experiencing those feelings, they're having a whole lot of thoughts too. But they're not considering the high road. Because the low road, that can happen in milliseconds without awareness. And what we want to do is we want to slow it down. Can you breathe? Can you name what it is you're experiencing? And what are you telling yourself about those? Let's think about some choices. Because when I have choices, I can move toward moments of control, and with conscious awareness, I can choose to behave in a particular way to work with, be with, or mitigate the intensity of these feelings. And this is another graphic. We can send the slides. If you reach out to Sakina, she'll have slides that she can share with you. And this is what we use in one of our other interventions. And this slide was created, I believe, by Sakina and Alex. And it gives far more information. People will often talk about feeling disconnected. So we want to know who is in your network and who fits within the different categories of the ecogram that we will show you in a minute. Who are the unconditional listeners? These are the people who can sit and listen to your pain. They can let you vent, and they can provide emotional support, make you a cup of tea, pass you a tissue, and no judgment. There are the people who are the instrumentalists or the doers. These are the people who can help get the groceries, give you a drive to the doctors. They may not be so good at sitting with a cup of tea and handing over the Kleenex. So can you know and identify the difference between the different people? And then who are the people that help you just go out? Go to a movie, go for a walk, go for a hike, go for rock climbing, go for a swim, but they do something so they help distract you or take you away from the experience that you're going through in the moment. And then, of course, who are those toxic people? They're the unhealthy relationships that we sometimes have, where we think we're giving more than we're getting back, or we just sort of hold back because there's nothing we can do, or they infantilize or paternalize. These are the folks where we don't feel so great, especially when we're not feeling well. And so this is the sociogram. And the categories include family, community, and neighbors, crisis contacts, role models. Who would you like to be like? Who's your favorite cartoon character? What attracts you about that person? Who's your fairy tale person? Who's your favorite podcaster? Who's your favorite YouTuber? Those kinds of things. Who are the professional resources? And what about the friends and peers? What about the online chat rooms or crisis lines that you can text or reach out to? And let's recognize that the most important person on your network is you, because you are the one who is going to be able to make choices to keep yourself as safe as possible. You have strengths, you have skills. If you've had thoughts for a while, or you've made attempts and you're here talking to me, you got lots in there that's workable and that's on your side. So when we have people on our networks, we want to let them know they're on our networks. Ask what they feel comfortable with. Don't make the assumption that they're going to appreciate a phone call at 3 o'clock in the morning because you're having a night where you can't sleep and you're getting more and more agitated. Who are the people who are good for emotions and who are the doers? Know when and when they're not available. Who's good for what? Who's good when? How to ask for help and who not to call. It's important that you know just because this particular person is on your speed dial, it doesn't mean they're the person that you need right now. What are your expectations? Can you name your expectations both for yourself and for other people? We talk about the scale of intensity. Excuse me, I'm just going to have a piece of tea or a bit of tea. The scale of intensity is unique to each person, and it has a number of different elements. What do I feel in my body? My early warning signs. What are the feelings that I'm experiencing? Emotions. What are you thinking? What are the strategies or the choices that you're able to engage in? I can. What will you engage in? I will. And that's back to taking a risk. That's back to the triangle, being conscious of your moments of control. So when we're looking at the scale of intensity, we want to name those feelings, the early warning signs, the people and places I can go to or reach out to, and what are the strategies that I choose and can choose to use. And let's remember, when your brain's offline, you need this somewhere where you can see it. And it's always helpful to have somebody else who has a copy to help remind you. Because, some people will say, well, somebody's learned all of these skills. Why aren't they using them? Well, it's because their brain is offline and they can't remember right now. And they're calling you to say, well, how about, have you thought about could you consider, rather than do, do, do. Again, I want to keep on giving the person the agency. I have to, as a therapist, recognize that I am not responsible for their decisions. I can walk with them, I can co-journey, I can't do it for them. So you're all probably familiar with the safety plan. This is your basic safety plan, and we've also added, what are the obstacles in using a safety plan? And what are the ways in which I can deal with those obstacles? Name them, tame them, right? Takes you back into a moment of control rather than the feeling of helplessness of this is useless, this is worthless. Oftentimes people will talk about having to do a safety plan, but they see it as a get out of jail, get out of the emerge, get out of the inpatient unit, as, you know, your free card. Do this and they'll let me go. It's got to be utilizable. It's got to make sense to the individual. And it's not a grade 3 substitute teacher paper pencil exercise. This is a conversation. And in doing an assessment and talking about who's in your life, what are some of the things you've done to help keep yourself safe up to this point? What are the situations that take you to a place where you're more vulnerable? How do you know it's getting a little rough? These are all elements of the safety plan, which in fact, if you have the conversation, this starts to conclude your discussion with the individual, or it begins the safety plan so that you can follow up with, let's talk about this next session. We as care providers play a really, really important role. Suicide is challenging. Not many of our professional bodies have done a decent job of training us in working in this area. It is something that is very, very highly feared. We have institutions and agencies which will investigate us if one of our people die by suicide. So it's almost as if you're walking around thinking, it's all my fault if this person does this, right? We need to recognize we do play an important part. We can't make anybody anything, and we are not responsible for their decision to live. What John Cutcliffe identified is that collaboration, respect, and individualized approaches with an inherent belief in the value of this person are critical. We've got to be able to sit with the person's pain. The risk assessment is not the ticky box. It's about a conversation, and the assessment gets interwoven. So the assessment is, in fact, an intervention. They are not separate conversations. And when we're having a conversation, we're building a relationship. We're building an alliance. And this can help the person feel safer. Maybe not totally. Let's remember, some people never feel safe. There's also the need for the shared understanding of the suicidal client's psychological and emotional pain. If someone says to me, oh yeah, they're here again, you know, it's that personality disorder diagnosis. That's not showing me that you understand what brought them here today. Well, it's the same old, same old. You know what? For that individual, the experience is unique. Today's experience is different from when you saw them last week. It may sound like the same story to you. It's not the same experience for them. So what is it that they are, in fact, understanding? Because when we're working with somebody, this is a collaboration. It's a we. Yes, I may, as a care provider, hold power, but let's not make it a paternalistic thou shalt power. Let's recognize that I care, I'm here. And somebody once said to me, one of my clients said, you're just doing this because you're paid. And I said, I'm paid to do a job. The caring is extra, right? And as one of my colleagues once said, is this a job or a vocation? And how do you see your work? How do you interpret yourself in your work? Our facilitators are invited to consider the assumptions that we work under. One, when they're not in crisis, they're capable individuals, they have strengths, they have passions. And if they've let you know that they're in crisis by coming to you, that's a strength. They're capable. They were capable of reaching out. That voluntary participation shows that they're either curious or consciously, maybe unconsciously, wanting to change their lives and live life differently. They just don't believe that it can happen. And so that's where saying, you know what, there's all kinds of possibilities. Tomorrow's going to be different because by the end of this conversation, there might be something you didn't know before. It's the participants who are responsible for making the choices to help themselves. And it's their ability to learn new and more adaptive coping strategies. We have had people who are on the spectrum. We have had people with developmental challenges. We've had people with traumatic brain injuries as part of our groups. For some people, it's the structure. For some people, it's sitting in the room with other people. For some people, it's just understanding and being able to say, I don't feel safe. I don't feel safe, versus behaving that feeling of who knows, they can't name it. And that's okay, because they walk away saying, I can keep myself safer. Participants are both the learners and the teachers in terms of living life more safely. We too are learners. We remain curious. We don't know it all because I don't live inside their heads. And if a client tells me that they hear my voice in their heads when they're at home, I just ask them if they're charging me rent, because it means they have started to internalize. And by virtue of having a thought or attempted to end their lives, they may in fact be experiencing trauma or a moral injury because it's against culture, religion, family, or social protocols. It changes relationships. And that can be a traumatic experience for an awful lot of people. And we need to recognize how that might be. For some people, surviving an attempt is a traumatic event because they had really wanted to not be here. The core competencies that we ask are that you work from a person-centered framework, that you're able to collaborate with clients and with your fellow team members, that we ensure choice and control for clients, for ourselves, and one another, that we are continually educating ourselves to make sure that we are as anti-oppressive and culturally sensitive as we are able and willing to learn more. And as I've said a couple of times, we can't make somebody do something just because we want them to do it. We come inherently from a place of curiosity and compassion. These people are hurting. There is pain. And just understanding that and being with them in that. And at the same time, you can't take care of other people if you're not taking care of yourself. So what are you doing to care for yourself? And what is the personal work that you're engaged in? Because we will, in fact, experience countertransference when we're working with someone who wants to die. Sometimes we get folks where we just feel trapped in an impossible situation, and we pick up the hopelessness and the apprehension and the helplessness. And, in some ways it's like, I just don't want that person to come. Thank God they canceled on me. And then it's oh my God, are they okay? Are they safe? Some of us experience real personal and professional satisfaction and we're very hopeful. We carry the hope silently. We talk to them about possibility. We carry the hope inside of us, right? When we engage with the person. Sometimes we have the experience where we think we're having something happening. There's a real activation happening, right? What's going on here? Is it sexualized? Is it competition? Is there envy? Am I not liking the person? They're not liking me. And they've got all these reactions, and we get reactive, right? Sometimes there are folks who say, I'm the only one who can help this person, right? And that can lead to a real porous therapeutic frame, right? And it might lead to boundary crossing. And we need to recognize that boundaries is one of those things that may not be hard and fast, and they're different for everybody in terms of their skill, their capacity, their capability, right? What I might feel comfortable doing, you might not, and that's okay, right? We all have what we are able to tolerate or not. The question is, can you then reach out to somebody else to say, I'm really not comfortable with this. Will you be with me or do this with me? Or could you take it over? There are some times when we find ourselves totally over involved and very, very protective. I'm a mother bear when it came to my clients in so many ways. And sometimes that's because I feel responsible, right? And have to take a step back and go, Yvonne, their choice is not up to you. You can't make them do anything. And then sometimes, you know, some days I'm really on, some days I'm not on, and I'm a little inconsistent. And, I'm just sort of not there therapeutically. And then, there are people who will, in fact, and I'm sure some of you have experienced or seen or heard this, is that there's a sense of being criticized or manipulated or denigrated. And that will just make us more rigid and more controlling. And paying attention to these things is really, really important, which is why when we're working with folks in groups, weekly supervision is mandatory. And we have peer facilitators who are graduates of the program. They too are part of our clinical supervision team. And, okay, something is happening. So Soulier also did some recent research looking at countertransference and found that those of us who really, really enjoy working in this field with our clients, and they are able to manage the countertransference, right? So they have very few countertransferential responses, and there's greater positive involvement. So they identified that sorry, I am just looking at my slides going, Yvonne, what were you thinking? Ever had that? Yeah, so that the positive inclination is not necessarily countertransferential. And the clinician may, in fact, from time to time, experience some of those negative countertransferential pieces. And yet, they can manage it. They have better and more positive emotional responses to our clients. And there again, supervision, having a place to debrief and a safe place as a clinician to go, oh my God, and then say whatever it is you need to say in whatever way you need to say it. So as providers, we need to remember that this is not about you. It's about the client alleviating their own distress. And know that, yeah, You're human. You can, in fact, feel the revulsion, the anger, the fear, the distaste, the disgust, the scared. And that's okay. Those feelings that you're experiencing are useful. Stay curious. Talk to your supervisor, your peers, read, learn, listen, go to workshops. And there, if you want, are all the resources that I use to put this talk together. And maybe we actually have time to be able to answer a few questions or have a conversation. Thank
Thank you,
you.
Yvonne. It's
Gonna end.
always a joy to hear you speak about everything that you're talking about. It's so impactful. And maybe also new for people in terms of a different way that they're thinking about suicide and all their own suicidal thoughts. And a lot of people in the chat have been very appreciative of this talk as well. So there are some questions that people have. And one of them, like maybe just to start off, is how can you talk yourself out of suicide ideation? Is one question from the group.
I'm not sure you can talk yourself out of it as opposed to what is the ideation telling you? What's going on in my life right now that has my brain saying, yeah, we don't want to stick around for this? What is it that you're feeling? Can you name the feeling? Does it require a cry? Does it mean a punching bag? Does it mean a conversation? Does it mean a vacation? It's not so much. I think one of the things that we often say to folks is a feeling can't kill you. A thought can't kill you. What you do with either could, right? And recognizing that, in fact, you know what? How can I name it, tame it, and recognizing that the intensity will go down? Can I also pay attention to when I'm not having those thoughts? Right? What am I doing? Hey, wait a minute. I didn't have any thoughts. What was I doing? Right? What was I engaged in? So, it might be one of those friends you just don't want to see all the time, but they're still around, or a neighbor. It's how do you interpret that relationship? Does that help at all for the person who asked?
I hope so. Feel free if there is a follow-up question to that to ask in the QA. There was another question on, is there a working definition of what the differences are between helplessness and hopelessness?
I don't know what the working definitions are. I haven't gone to ChatGPT to ask. My own thoughts are that the helplessness is, I don't know what to do about this. And the hopelessness is, there's nothing I can do about this. That's how I would understand the two.
Yeah. They're very intertwined, I think. But yeah, I think there's definitely a little bit of nuance there.
Mm-hmm.
Another question is, are activities like this mainly for youth, like the feelings in the body, drawing like the URL, or, feelings being labeled, or are there ways you would recommend adjusting them for older folks?
Oh, we play with Komochis and we do Earl with anybody, everybody. As I mentioned with the Komochi game, we had a 75-year-old who was equally as active, and people learn better when they play. They take it in better when they play.
Mhm.
And so wherever we can, we play. And people aren't complaining about feeling like this is grade school, which I find fascinating. It was like, gee, that was fun. Or I never knew that. It's really quite fascinating to me that I think inherently there are a lot of people who kind of missed out on play, and you get 15, 20 minutes in a group and people are giggling.
Yeah.
You're
Yeah,
banking.
and for sure. Play can be very inadvertently shamed as we get older. And then also we forget, like, oh, I forget how to do that.
Mm-hmm.
So it's nice to kind of be in a space that actually allows you to do that again. Um,
And I think as therapists, we need to loosen up and play too.
yes,
You know?
that too. There's questions here, which I'm not surprised, but like how do people get started in facilitating SfSL in their community? How do they bring it to new locations? Is there manual training facilitators that they have to complete?
Yes. So at this point in time, what we're still doing, I'm doing, is a 5-day training for folks. We do it either virtually or in person, depending on the travel distance from where I am to where the other people are. It's 5 days. We've done it in different ways where we have 2 full days of theory, and then we have either another 3 full days of experiential. Online, what we do is 2 days of theory, and then the following week we do 3 half days of experiential, and the week after that another 3 half days of experiential. We've had in person where we'll do 2 days of theory, and then we'll break up the experiential so that people can take it back and play with them. It depends on the agency and the demand that is placed on workers. For the virtual, we do it half day because we recognize that the other half day people will want to get in touch with some of their clients. So the way in which I've got a 1-pager, if you're interested, we can send that out to you, just about the process and how that works. One of the things that we ask, pretty much demand, although I really don't have a whole lot of control when things get up and moving, is that there is a supervisor who is familiar with suicide and with groups and group psychotherapy. If you're not trained in group psychotherapy, the Toronto Institute for Group Studies does do online training for group therapy. And it's always advantageous if the supervisor and or manager takes part in the training.
I know, Yvonne, we've been talking about doing SfSL on an individual basis and not in a group setting. I wonder maybe if you can speak to that.
Absolutely. I cannot tell you the number of facilitators that we've had over the decades. I have to, it's really hard to believe this has been going on since 1999. Anyway, the number of facilitators who say that they use it in their individual practice and take bits and pieces out in their individual practice with clients at varying points, whether they have suicidality or not.
Okay. Um, I think this is a really important question. What would be a first step or actionable thing we could do when having a loved one living with ideation?
Keep loving them. Keep loving them at the core. You got to keep loving them. What I would probably, depending on what's going on at the time, if I'm starting to get or hear the thoughts or they're starting to behave, I think what's going to happen is I'm going to name what I see. When you X, Y, or Z, I'm understanding that you're in a lot of pain right now and that something's really hurting. Do you have the words? Can you tell me a bit more about that? If they tell you to take a long walk off a short pier or other such youthful language, you can say, you know what? I love you. I'm concerned about you. And this is still telling me that there's something really, really impacting you or hurting you right now. And I really want to be able to listen. I know that one of my clients at one point said that they went to somebody and the person just looked at them and said, I have big ears. I'm willing to listen. And they said that made all the difference for them. Trying to convince them out of it could turn into a battle of wills. Being non-judgmental and saying, rather than, well, you can't do that, or trying to say, but what would it do to this family, isn't necessarily going to work either. It's about, this is really, really painful for you, and hearing it is painful. And I'm okay with that because I want to know. I want to be here for you.
Yeah.
So, do you have anything you want to add from some of the interviews?
Yeah, I mean, I think that a big piece, especially for caregivers, and I do a lot of work on bereavement for people who've lost someone to suicide as well. And a big thing I think that can sometimes get in the way is that you don't actually have, like Yvonne kept saying, you don't have control over this decision, and that's scary as hell. And so it makes sense that that fear is going to come up, and you want to like you want to fix it when actually the thing that actually helps is the sitting with. And when I was 18 years old, like I started working on like crisis lines like as soon as I could, and my first two calls were people with suicide risk, and they just wanted to talk. They wanted someone to hear them, but not just listen, but actually hear what they were going through and understand it. That wow, that's really hard. And I think that sometimes that sounds simplistic, but I'm telling you, even as therapists, it's like this piece is so crucial, is just being able to just be with someone makes such an astronomical difference
One of
in a non-judgmental space. Yeah.
there was a therapist out on the West Coast whose name escapes me right now, back in the early 2000s. And he said, our clients so much don't want understanding as much as they want to be understood.
Yeah. Yeah, for
And
sure. Yvonne, there was also a question on where people can access groups that are currently going on.
currently, there are groups in Wellington, Waterloo region. So that would be Guelph, Cambridge, Kitchener, Waterloo. Starling has youth groups in the Waterloo region, I believe. I think they're Waterloo. They're out in that area. Alberta is working on, through the Center for Suicide Prevention and the CMHA, are looking at offering the 4-week youth caregiver program. Kenora, CMHA is currently offering groups as well, and we've got another training for another load of their workers coming up. There's
Are people doing online, Yvonne? Is it all like in person? Okay.
There's online and in person. In Toronto, for gay, bi, and trans men, there is a group for ideation, and also there will be one for people with attempts at a community health center called HQ.
Yeah, someone was asking about having this globally, and the challenge with that is our restrictions as therapists is we're not actually allowed to, like, even outside of Ontario, we have to get permission from another province to see somebody. So that is kind of create some limitations of being able to run this globally. But we were actually able to get permission to run our single session across Canada. And Yvonne and I are currently working on developing that training. So stay tuned for that as well. I know we're over time, Yvonne. How do you feel about a few minutes more for questions?
Sure, I'm
You're good to go?
Yep.
Yeah, okay. Since they have you as a captive audience here. Talia was asking, what is the most common challenge facilitators typically face when running suicide prevention groups, and what recommendations do you have for that type of challenge?
Depends on the facilitator. Right? It really does. I think one of the worries that always happens is somebody coming in highly escalated. And how am I going to run a group and be able to work with this person and keep an eye on them? In when you're doing in-person groups, It's the person who walks out of the room without giving you a thumbs up or a down to say whether they're or not they're okay, which means you need 2 to 3 facilitators in the room. I always had students from multiple disciplines. I also had peer facilitator plus one other regulated healthcare professional with me for those moments when somebody needs to step out of the room and they need a little bit of support outside of the room. Online, it's 3 facilitators, 2 for the group, 1 as an observer to help with tech issues and people who drop off. You know, like suddenly they disappear when they're online. And so the third person is contacting them, calling them, emailing, etc., to ensure safety and that it's not a technical glitch. So it's when they disappear when I'm in the group. That is extremely challenging as a facilitator. So have a buddy with you.
Any tips on how to connect specifically with men? This one attendee has questions about that and feel like they're a bit harder to open up.
Yep. You know, that's a really, really good question. I can just give you how, like, I would often see people either on the inpatient unit or in the emergency department. And so my first question is never what brought you here or how are you doing? I was going to read their body language or their face and say, whoa, for you to be here right now, you got to be in a lot of pain. So I go straight for affect because I don't want to get into brain wars. I don't want to get into the rationalization war. So I'm going to go straight for the gut in terms of affect. So when somebody, you know, if I've got somebody who I haven't seen in one of those contexts and they come in, I'm going to, again, because when I was doing the groups at St. Mike's, it was people all had recurrent suicide attempts. I was able to just open up and say, so the fact that you're seeing me means that you have tried to end your life 2 or more times. So what is it you were trying to end? And then we get right into that conversation. I didn't have a whole lot of preamble. The other thing I think, and this is just, it's not just, this is a personality thing as well, where I'm very transparent and upfront. And I will say to people, I work with people who have all had 2 or more suicide attempts at any given time. I don't have a whole lot of time for bullshit or for you to be untruthful. I will be straight with you, and I expect you are going to do that with me. And if there's a problem with something that I have said or done, you have to ask me about it. Right. So that we have that open communication, because sometimes, you know, I do stick my foot in my mouth and I would really like to know when it's in there so I could pull it out. Right. So with the men, it's go for the gut and be clear about what the ground rules are and still let them know you care about them in their little, because, you know, when I was working with young offenders, one of the things I always said about them was they were in fact candy coated marshmallows, or sometimes they were concrete covered, but we had to find the little fissures to be able to get in.
Yeah, I think that we have to acknowledge that in our culture that men and women are socialized differently around emotions. And so going to someone who hasn't been socialized for it to be safe to talk about their feelings, to say, tell me how you're feeling, they're going to run away from you as fast as they can. So you really have to work with their language, use different words. I don't use the word compassion with some male clients. I'm like, what is that? What is that word for you? It was like, they're like, yeah, like showing up for myself. So you might need to use different language as well. Like I remember one man telling me, he's like, we're only allowed to experience 3 emotions. And that's like anger and fear and maybe happy. So if you're, like no, sorry, no, it wasn't fear. So if you're scared, then you get angry. If you're feeling anxious, you get angry. So that was kind of his challenge, where it's like this was what was normalized for me growing up, and you can't kind of just yank someone out of that.
Mm-mm.
So I think that's kind of an important piece as well. Um, is there SFSL for first responders?
Oh, I would love it.
Mhm.
So I have had first responders who have been in the groups, but that's on their own time and when they have had to take time off. But oh, I would, yeah.
Yeah. Um, there's several people who are asking about where to get groups, and I think Yvonne, you're saying you have a one pager of where the groups are, so we'll send that out to
Oh, I
folks.
don't have a one pager where the
You?
groups are.
Okay,
No,
okay,
no, no, no. But as I said, Wellington, Waterloo, Toronto, if the person is gay, bi, trans male, Alberta for youth and caregivers.
okay.
Yeah.
Okay, maybe we can actually kind of, you always get questions about that, so maybe we can actually put that together, Yvonne, and send that out to folks as
Yep.
well.
Yep.
And I think maybe I'm gonna end with one last question, maybe, which I think is a difficult one. In the context of MAID, and for people who are wondering what that is, it's medical assistance in dying. And currently, the Canadian government is assessing whether to expand that to mental health, and their deadline for that is March 2027. So, a couple of folks have asked, like, can skills for safe be helpful for someone considering MAID, where their primary underlying medical conditions, mental illness, or how do you balance help with suicidality and living safer, or someone's considering MAID, kind of lumping that into that all in one question.
Yeah. One of the things that I probably looked like a crazy old driver when I was listening to the interviews for people who experience mental health challenges and have been advocating for MAID is, have you had any treatment for your suicidality? Have you, in fact, participated in coming to understand your suicidality? Loads and loads of people live with mental illness. I can live with schizophrenia. I can live with, or, like, I mean, and these are broad statements. I know that it's unique for each individual. But have you learned how to cope with what and understand what the suicidality is? Is it about the misery of having the diagnosis or being seen as, somebody who experiences voices, or that the voices are never, ever, ever stopping? Or is it about the emotion dysregulation, that you don't fit in anywhere because you get so reactive? I mean, let's work with the suicidality and treatment, right? And I think that's my biggest bugaboo, is about, well, we haven't explored all the options because all the options haven't been made available, and you've been denied the availability of options, right? Whether that be lack of resource, the fact that programs aren't available to you, the fact that there are wait lists from here to next year. And, when it was initially being discussed and clients would come to me, I have to say, I took the easy way out in terms of saying, I'm a suicide interventionist. If you want to work with me, you need to be alive. And so perhaps we can work together for the next 20 or 40 weeks, whether they chose to repeat the program, and then let's revisit where you want to go with the whole concept of MAID, because I could offer them something. I can't imagine what it's like when there is nothing to offer somebody.
Yeah, and I think that there can sometimes be perception that, say, for example, if you treat the depression, the suicide goes or suicide risk goes away. If you treat the bipolar, we know that that's not necessarily true. And I think that what really struck me about doing the single session intervention across Canada is that I always start off asking, what's been your experience with mental health professionals talking about your suicide risk? It's like, oh, that wasn't really a focus. But we know that if we get really laser focused on this one thing, that we can actually move the needle, right? But it actually hasn't necessarily even been directly addressed
I
in
had
some of the
one,
treatments that people are getting. Yeah.
yeah, I had one group graduate contact me last year and said, I'm now in a therapy, and they said suicide is off the table and I'm not allowed to talk about it. How can I be forthcoming and honest with my therapist if I can't talk about the very issue that I struggle with
100%.
from time to time?
Yeah. Yeah. This isn't something that someone, especially if they're seeking out professional help, but they should have to deal with that alone. That's the reason why they're going to get help for it. So I think that as a profession, we can do a much better job of training people to do this.
Absolutely.
Um, and so like lobbying to like some of these colleges that this actually needs to be more focused on in the curriculum because it's actually not, which is very surprising.
Mhm.
Um, so I think that there's definitely things there that we can do better on.
Yeah, it was
Uh,
my clients who taught me.
yeah,
Taught
yeah.
me how to use the language. They taught me what was needed and necessary. My college, neither of my colleges taught me any of that.
Oh, you taught me that also. So again, we're gonna create a list of where people can access some groups. So we will send that in an email to you because I know people ask that a lot. And it's good for us to just have that resource available for folks. So thank you so much, Yvonne, for being so generous with your time as well, and taking an extra 17 minutes to answer questions. It was really appreciated. And thank you just for all of the work, incredible work you do. Really, like you have such an immense impact, and yeah, can't say it enough. So, and thank you everybody for coming. Our next event is on November 17th on Monday, where we're going to actually have Feroza Mamdani from University of California, Irvine, speak to us about blood-based markers for suicide risk. So we're going to kind of run the gamut here and talk about everything when it comes to suicide risk. So thank you everybody, and we will see you next month. Bye.